Welcome to week 6 for hematology. We are going to go through 2 PowerPoints this week, so I'm going to make sure I share my screen here right away. And we will be finally tackling leukemias as we've referenced them a few times throughout this quarter. So we are going to delve into that today. Let me put this in slideshow format. So specifically acute leukemias. Again, remember the deal with acute leukemias. Acute has lots and lots of immature cells, especially blast cells involved. So we will start with ALL. They're always going to let you know what cell line is heavily impacted by the middle word. So lymphoblastic, acute lymphoblastic leukemia. Then we know by that name, it's all about the lymphocyte lines being impacted. ALL tends to be the leukemia for children. So usually 2 to 10-year-olds. So if you ever hear of a child getting diagnosed with leukemia that's kind of in that age range, it most likely the type of ALL. Almost always. So that's pretty much the main connection there for age group. Prognosis is just going to depend on a few things. It's going to depend on the age of the child at the diagnosis time. It will also depend on what type of ALL they have. There are different chromosomal translocations, different types of ALL, and so it just depends on which one they end up having. Now, because there are 2 types of lymphocytes, remember we have B cell and T cell, you can have ALL, either B cell ALL or T cell ALL. It'll be one of those 2 that get affected. And again, because it's an acute leukemia, you will see lots of lymphoblasts on the smear and in the bone marrow. Now, lymphoblasts look like any other blast cell. You're not going to know the lymphoblasts, but that's what it would be. We can use the cytochemical stains, the CD markers to figure out that it is a lymphoblast and making it ALL. So that's kind of how we determine it. There's actually 4 types of ALL identified overall, but in general, all of them share very similar clinical features. Usually you do see splenomegaly, hepatomegaly, which are enlarged spleen, enlarged liver. Lymphadenopathy is a big one here, which is enlarged lymph nodes. If you think about that, yes, this is a leukemia. It's all about the bone marrow being impacted, but since lymphocytes are so heavily found in the lymph system, that's why it's called the lymph system, lymphocytes, once they are made in the bone marrow, they kind of travel to different organs, like the thymus, they get developed into a T cell. They go, and a lot of them reside in the lymph system. If you have ALL, which is all about lymphoblasts and all this stuff happening, you're going to have enlarged lymph nodes too. Neutropenia, thrombocytopenia, anemia. What these result from, and we're going to see this with the other acute leukemias, is your bone marrow is now making huge amounts of an abnormal cell, like lymphoblasts. All of a sudden, the bone marrow is putting out tons and tons and tons of very immature lymphocytes, so all these lymphoblasts, and they're not really making anything else. You're not having a lot of room for red cells. You're not having a lot of room for platelets. You may not have a lot of room for some of the other cells, like neutrophils, because the bone marrow has become too crowded with all the lymphoblasts that has put out instead. As a result, when you're missing those other cell lines, you get these terms that coordinate with that. So it's just simply we have way too many young immature cells and not enough room for the rest of the stuff. And again, remember, these immature cells, these blast cells, do not function. They don't do anything for us. They're like babies. They have no job in life. And as a result of having no job, it's really hard on the patient. That patient doesn't have the ability to fight off disease very well, infection. They don't have the ability to clot very well with platelets being low. They don't have great oxygen carrying capacity with the red cells being so low. So it's really hard on the patient, and that's what eventually takes a toll on that patient, and that's where you see the prognosis going downhill the worse it becomes. Bone pain, huge one with ALL especially, and that's tough with children. When you think about it, children are growing, and so as a result, they naturally have kind of bone pain from growing. But then you're like, well, there's also bone pain with ALL, and this is mainly seen in children. You just have to use your gut instinct and any other symptoms or signs that might be present. All right, so let's switch over to acute myeloid leukemias, AML. Because this is the rest of the cell lines, all the others, it can be red cells, platelets, neutrophil, eosinophil, basophil, monocytes, there's a lot more options of AML out there. So we're going to cover about 8 AMLs here because there's all the cell lines involved. Now, this is a common leukemia for children under a year and then tends to peak around 40 years and up. There's definitely people in their 20s that get this. I mean, it doesn't mean that these are the only ages they can get it. It can happen any age range, unfortunately. So again, with AML, you're going to see a lot of the same clinical features as we kind of just went through with ALL. Usually it's a higher white count. You'll definitely still see that anemia, thrombocytopenia, neutropenia, bone pain, splenomegaly, all of that is still present, just very similar. Leukemia clinical signs are pretty much the same. In this case, we're seeing lots of myeloblasts because it's an acute myeloid leukemia. So we're going to see the blast cells be of myeloid nature usually. And then at the bottom, you see a couple different things. Hyperuricemia, what that means is a high uric acid count. And then hyperkalemia, which is a high potassium level. These happen because your cells will carry certain things like your red cells, we all know, carry potassium inside of them. That's a big thing found inside in red cells is potassium. Uric acid is also carried. When in a leukemia situation, your cells turn over more rapidly. When they turn over and are destroyed or dying, they release out their substances that they have. Well, if you're turning over a lot of red cells, they're releasing out a ton of potassium. So as a result, with that, we have a high potassium level. So these kind of coincide with that. So anything that might be inside the cells, as they're getting turned over, gets released, and then we get a higher count. LDH is another one, high lactate dehydrogenase. That's an enzyme. That's also found inside cells. We tend to see a high level of that as well, since the turnover is kicking it out. All right, so remember, we have FAB and WHO have classified the leukemias. FAB classified just according to morphology. WHO classified to a lot of things, and here we can see the 4 categories of how they classified. They had a category for just those that are known cytogenetic abnormalities, like known chromosome translocations. They have a category that has multi-lineage dysplasia, meaning more than just one cell line is involved. They have a category with myelodysplasia as a result of therapy, and then they have the 4th category, not otherwise classified, which is just kind of random. We are going to mainly hit up the 4th category, and we'll talk about one in the 1st category, but we're still going to learn the FAB classification system because I know in your board study guidebook they still have questions on it, so we need to make sure we cover that information. In your textbook, it should cover how the WHO has it displayed out, but we will definitely hit up that last one, and then we have one with a cytogenetic that falls in here too. So we're going to get you enough of what you need for leukemia. The nice thing about leukemias is because all their clinical symptoms are the same, you don't really have to learn new clinical symptoms for every single leukemia. All you need to learn to differentiate between the leukemias is what cells are involved. Knowing what cells, and then that means knowing the CD markers that go with them and the cytochemical stains. So that's the things that will differentiate those lab results. So in general, in acute leukemias, it talks about an MTE ratio of greater than 1. That is basically when you look at the bone marrow, you're going to have way more myeloid-based cells being produced usually than erythroid. And again, in order to be an acute leukemia, you have to have at least 20% or more be blast cells. That makes an acute leukemia. So that's the one that's going to be the recurrent cytogenetic that has a chromosome translocation. I'm actually going to hang on to this and come back to it when it's time. Because you see this number M3, it fits into an order system for FAB. So hang on to the slide. We're going to come back to it. So all right, so I said, you know, this one right here, this AML with myelodysplasia, you can just ignore this. I would cross this slide off. It is not important in what we need to know. So if it's just easier, cross it off. Don't worry about this. We're not going to test on this slide here. Like I said before, we're going to test on the ones that fit into that not otherwise categorized feature, not otherwise classified, I think it was called. So these are kind of grouped according to morphology, which is the FAB part, flow cytometry, which is the CD markers, and then cytochemical reactions, which again are the stains. So the numbers in parentheses, the M and then a number, is standing for the classification of FAB. It will start with M0 and go to M8, and those are the, or go to M7, and those are the 8 leukemias that we're going to remember. So we're going to start with M0, which is known as AML minimally differentiated. So that's M0. So in this leukemia, you are going to see a ton of blast cells, like greater than 90% of that patient's cells are going to be blast cells, greater than 90%. That's insane. Now, the minimally differentiated is referring to these blast cells are so young that they just have barely begun to be a blast cell. If you think back to the order of the chart, how things mature, right before the blast cell stage was like a CFU cell, you know, those weird progenitor cells. That's what it was. It barely got out of that progenitor cell stage and just barely become its blast cell stage, and that's the leukemia. So because they're such young blast cells, none of the stains really work for them. So the stains aren't going to work here yet because they're too young. When the next one we'll see, they will start to work. But if you were to look for CD markers, because they are myeloblast in nature, which will lead eventually to neutrophils and eosinophils and stuff, you'll see 13 and 33 still show up. Remember, 13, 33 are the granulocyte markers. 34 always indicates a blast cell, and then we don't care about the CD117 for now. So those will still indicate really heavily myeloblasts. That's how we know they're myeloblasts. But none of the other stains will work just because they're really young. So that's M0. M1 is called AML without maturation. So we still see greater than 90% be blasts. But these blasts, these myeloblasts, are a little bit more settled into their blast role. Now the stains will work. So you're going to see the same CD markers here, but you'll also get a positive myeloperoxidase and a positive Sudan black B. Remember, both those stains told us we have AML. When those stains are positive, that says AML. The other thing we'll see show up are our rods. We discussed our rods in that same chapter. Remember, those are the fused primary granule inclusions. Whenever you see an our rod, it's always with AML, and we will see our rods in the M1 stage. They will be inclusions in the cytoplasm of those blast cells, huge indicator of an AML occurring. So M1, tons and tons of blast cells, 90% and more, and then again, now we have positive stains show up to say, yes, AML. So that's M1 without maturation. M2 is AML with maturation. So as the name tells you, lots of blast cells, but now we're having a little bit other things show up. Now we go from, we have lots of myeloblasts, and now we're also having some promyelocytes show up. That's the next stage down. So we do see some more promyelocytes. We might even see a myelocyte or two. So we have a few other things involved. That's the with maturation part. We still get positive myeloperoxidase and positive Sudan black B stains, telling it's an AML, and we still see the our rods present as well. Now, I will go back to that slide, that M3 slide. This would be the next one in the order, the numerical order. M3 is called acute promyelocytic leukemia. As the name tells you, tons and tons of promyelocytes. Yes, we saw like 20% blast cells because it's an acute leukemia, but it's majority otherwise promyelocytes, and that's why they name it promyelocytic leukemia, because it's all about promyelocytes. This one, if you do hear somebody in their 20s that have leukemia, it might be this one as a potential. It kind of does happen to younger adults. Now, with these promyelocytes, and I know it's been a long time since we talked about promyelocytes, but a promyelocyte has granules in it. And with this leukemia, you might see these promyelocytes become hypergranule, meaning tons of granules, and they're going to have lots of our rods because those granules will all fuse together to start to become our rods. So you have lots and lots of granulation in our rods. And in fact, you have so many our rods that they nickname that cell a faggot cell. Now, faggot doesn't mean what you and I think it means with the slang. It means actually bundle of sticks. And so when you look at it here, look at all those our rods in the cytoplasm. That's the bundle of sticks. So that's very much a linked cell to acute promyelocytic leukemia. So lots of promyelocytes, potentially hypergranular with lots of our rods. The other thing is this is well known linked with the chromosomal abnormality, and you need to remember this chromosome abnormality, and I think we talked about it once before. This is the one that's a translocation between chromosomes 15 and 17. So, and then the final thing to remember with this is with this leukemia especially, they have a tendency to the patient has a tendency to get to form DIC. Now, we've briefly talked about DIC in Hematology 1. We'll talk about it again in coagulation units, which is coming up. But DIC is that thing that occurs secondary. They might have leukemia, they might have a sepsis, they might have a really complicated pregnancy. It's something that's going on with the patient that puts them into this kind of DIC, and that's the one where they get clots all over their body, and they don't know it yet because they're smaller clots until it results in one big hemorrhage, and then it's like a dire emergency kind of situation. And this M3 leukemia is well known to cause that. All those granules are actually going to trigger out coagulation cascade and start the clotting process all over, and then that's the risk, the hemorrhaging later. So I will tell you my saying to remember this, and you can use it or you don't have to use it. So DIC, obviously, if you were to spell DIC and say it out loud, Dick, you just say 15 and 17-year-olds like Dick. So if you want to try to remember the chromosome abnormality with the tendency to have DIC occur, all about acute promyelocytic, maybe that's something that can work for you. If you don't like it, don't use it. All right. So now going back to our list, we were on M4. M4 is acute myelomonocytic leukemia. So the name tells you we do have myeloid blasts present, and now we also have an increase in monoblasts present. So we kind of have a dual representation here. So we will see those monocytic cells increase in number in this peripheral smear and some monoblasts present. Now, when you think back to our stains, the stains that would react here would be both the esterases. So your specific esterase is used to stain myeloblasts. That would be positive. Your non-specific esterases were used to stain positive for monocytes. They will both be positive here, then representing both dual populations. M5 is acute monoblastic leukemia. The name tells you all about monocytic cells. Greater than 80% of the cells are going to be monocytic in nature and monoblastic. So you would definitely see non-specific esterases be positive here. The specific esterase would be negative. So that's M4 and M5. M6 is acute erythroid leukemia. So this is the one that's involving the red blood cell line. There are actually two subtypes. You have acute erythroid leukemia, which are made of mostly pronormal blasts and then some myeloblasts still, and then you have the pure erythroid leukemia, which is only all about all the pronormal and basophilic normoblasts. There's no really myeloblasts in the pure one, so it's purely the red cell line kind of impacted. So remember with acute erythroid leukemia, that is the one that PAS can stain positive for. So that is M6. And then finally, M7 is acute megakaryocytic leukemia, so affecting the platelet line. That's our last cell line we haven't talked about. Otherwise, we've hit all the other cell lines. M7, very, very, very rare. But again, you're going to see tons of megakaryocytes. So it's that platelet line effect. No stains or anything for you to worry about here on this one. So those are the 8 leukemias. You need to memorize the names of each one, the number, the M number that goes with it, and then stains and CD markers. If you know what CD markers go with what cells and what stains work for what, you can put it together. We will have case studies to practice on this in your assignments, so you'll get a lot of practice putting this all together, and hopefully that'll help make more sense on how all this information works together to identify the leukemia. So the only thing I was going to emphasize was the hour rods. The hour rods are found specifically in M1, M2, and M3. Otherwise, there's not really hour rods in the rest of them. So M1, M2, and M3 are the ones that specifically have the hour rods. All right, so that's acute leukemia. I think it'll help when you guys start to do the case studies and put it into action. Now let's go to lymphomas. So otherwise known as mature lymphoid neoplasms. It's just fancy words for lymphoma. So again, a lymphoma is occurring in the lymph system. It's masses in the lymph system. Leukemia, remember, originates in the bone marrow. So that was kind of always the difference. So the biggest risk factor with lymphomas is altered immune function because lymphomas heavily involve lymphocytes, and lymphocytes are like our key cell in fighting with our immune system. Remember, B cells make antibodies, T cells help with cell-to-cell mediated immunity. They have such huge roles in helping our immune system. So when you have lymphomas that are impacting these lymphocytes, then you're going to have an altered immune function, and that really makes the patient susceptible to other diseases, and then that is hard on their bodies and bad prognosis kind of deal. Now, we've talked previously, there has been some viruses linked with lymphoma. We said specifically the Epstein-Barr virus was linked with Burkitt lymphoma. We'll see that. But there's other things that may result in somebody forming it. So we will go through our lymphomas, and we kind of have them categorized whether they're affecting the B-cell lymphocytes or the T-cell lymphocytes. So we're going to start with the mature B-cell lymphomas. The first one is it's a dual name. It can either be called chronic lymphocytic leukemia, CLL, which that is kind of more in the bone marrow, and small lymphocytic lymphoma, SLL, which would be more like the lymphoid part. Most people I know just call it CLL. I don't usually hear it referenced as SLL much, but again, it just depends on what the predominant site is involved. CLL, blood and bone marrow, SLL, lymph nodes, and lymphoid organs. The big thing with this one is you're going to see not blast cells. There's a difference. Because it's a chronic leukemia, you're going to see mature cells. So you're not going to find the blast cells like we just went through and discussed on the acute. Different story here. You will see lots of small lymphocytes. So they'll kind of look like normal lymphocytes, but they're, and you're going to see like 90% of your slide will be lymphocytes. It's kind of fun to count. It's like, oh, lymphocytes. And you're just dinging away on that in those lymphocyte buttons. There is a key cell finding, though, that is diagnostic for this, and that's called smudge cells. So at the very bottom, it talks about smudge cells are present, diagnostically significant. Sometimes a smudge cell is called a basket cell. I don't know in case you ever hear that term, but most of the time people call them smudge cells. A smudge cell is basically a lymphocyte that has been smudged out. It sounds just like it is. So in CLL, the lymphocytes that are there are fragile. They're not as strong as they are normally. And so when you go to make a smear, and you're making that smear, when you do the slide part, when you're making it, it can smudge out some of those lymphocytes as they're more fragile. And so when you look at it under the microscope, you kind of see this smudge. It looks like this. That is a fragile lymphocyte that got smudged out. And now, not a big deal, but in CLL, you will see many of these. And on your diff report, you have to talk about it. You need to say smudge cells noted. And in fact, it will go to the pathologist who will help agree with you, and diagnose it. But yes, these are very diagnostic to CLL. We don't talk about them with anything else, just with CLL. Now, some labs are going to have various things that they do. Do we count these in a diff? I would say no. You count the normal lymphocytes, but if you see a lot of these and you're worried that your number isn't going to be accurate because a lot of them got smudged out, a lot of sites will add albumin, which, if you think about it, albumin is a protein, and a protein will strengthen up that cell so that when you make the smear, they don't get smudged out and you can get a bit more of an accurate lymphocyte count. So it just depends on your hospital's policy what they'll do. So that is CLL. Okay, the next one is hairy cell leukemia. We've learned hairy cell leukemia briefly with the trap stain. So remember, it is a chronic B-cell lymphoma, so you'll see lots of small lymphocytes. The key, though, is they have that hairy cytoplasmic projection. Most of this is in the bone marrow, but you might see them here and there pop up in the bloodstream. And again, if we suspect it, we can perform that trap stain, and that should be positive. So remember, the saying is trap your hairy monster. And there's the hairy cytoplasm. All right, mantle cell lymphoma is another B-cell lymphoma. In this case, you'll get about medium-sized B lymphocytes. Again, lymph nodes are the main site of involvement. It is a lymphoma. Median survival, 3 to 5 years. It's a very nasty little thing. I don't think there's hardly much on this one in your book. If I remember the one edition, there was like 2 paragraphs. It's not that, I don't think it's that common, which is why they don't say much about it, but it's pretty progressive little guy. 3 to 5 years isn't long. Burkitt lymphoma, this is a big one. You got to know this one. Medium-sized lymphoid cells, they are going to have this basophilic vacuolated cytoplasm. So these lymphocytes are going to be very dark blue cytoplasm that has vacuoles in it. So that's kind of a key look. And then if you were to go to the bone marrow, you would see what they call a starry sky pattern bone marrow. And what, I think I have a picture. Yeah, here it is. I know at first when I looked at this, I went, they called it what? Starry sky pattern. I'm like, you guys are reaching. But what they're trying to show you is, one, very, very hyper kind of cellular bone marrow, lots of cells, no fatty patches. All the little white areas are basically macrophages. The bigger macrophages, remember, are kind of a bigger cell. That's why they stand out to you. That's the cytoplasm you're seeing of them. And what they say is the rest of the cells make the dark black sky, and the macrophages with their whiter cytoplasm make the stars. And that's the starry sky pattern. So here it says starry sky pattern due to numerous macrophages, and so that's what it's showing you. Clinically, hallmark sign of it is a high proliferation rate, or I shouldn't say clinically, but a hallmark sign is that these cells produce and produce and produce and produce and produce a very high proliferation rate. And again, this is the one that we have linked with Epstein-Barr virus in some patients. All right, going to, actually, I need to move this. I know I skipped this. I'll come back. The Hodgkin lymphoma, I think I mistakenly put this under T cell. This should be a B cell lymphoma, I believe. I think I put that in the wrong spot. So I would know Hodgkin as a B cell. I might have to double check myself there. Hodgkin, I think we've all heard of. I know I had always heard of it before I got in the lab. And this is one that typically affects like teenagers. That's who I've always linked it with. When I do hear of somebody having it, it's usually a younger adult, a teenage. I don't know if they're really adults yet, if they're teenagers, but you get what I mean. There are kind of two groups of Hodgkin's. We're just going to talk about the classical Hodgkin lymphoma. They have diagnostic cells in this called Reed-Sternberg. So again, it's a lymphocyte, but this lymphocyte's really unique in that it has two nuclei, and they call it Reed-Sternberg. So there are the Reed-Sternberg with the two nuclei. You can see them there, and this is a bone marrow picture. Once the pathologist kind of sees this, it's pretty diagnostic for being a Hodgkin. And then they also have another set of cells called Hodgkin cells, but they only have one nucleus. Otherwise, they look similar. But the Reed-Sternberg are really crucial for Hodgkin lymphoma. All right, that should be it for our B cell lymphomas. Now, let's talk about our 1 T cell lymphoma. So the 1 T cell lymphoma is Sézary syndrome. And this is weird because it's a lymphoma, but it's well known to have skin involvement. So it's kind of like a disseminated disease in that it's not just the lymph area that's affected, but skin can be involved here as well. So there can be some skin infections, basically issues. And now they do have a unique cell here as well called a circulating lymphoma cell. You can call it a lymphoma cell. You can call it a Sézary cell, but it's basically a lymphocyte that has a clefted nucleus. So that nucleus kind of gets split in half, or sometimes it's not always split all the way in half, but it has like a crack down the center of it. In fact, I used to nickname it butt crack cells. That was just my thing, but but it's the unique look along with Sézary syndrome. And so this is also another aggressive lymphoma, 5-year survival rate on this one. I think Hodgkin's is pretty treatable now if they got it in time. Okay, so that is your lymphomas. Please categorize them into B or T. Thankfully, there's only 1 T cell, so that should be a little easier. And just know some of those key cells that go along with each one. If you guys have any questions, as always, please feel free to reach out to me anytime. Otherwise, I hope you have a fabulous week. Thank you.